I hope I'm. Hello. Okay, let's start off with today's lecture. Today's lecture is basically on general anesthesia. So we have to start off from the beginning. Bismillahirrahmanirrahim. I'm Dr. Retired Hamid Mahmood. I'm a transplant anesthesiologist working in the transplant unit of Dow University Hospital. My key role is I'm the lead anesthesiologist for the transplant program, solid organ transplant program, liver and kidney. So today's topic is on general anesthesia. Basically, the anesthesia is divided into two parts. Uh, like, what is anesthesia? Let's start off with think anyone can share their comments on the side. I hope so. There, I will be able to see it on one side. Anyways, so what does anesthesia mean? The word anesthesia means absence of sensation. And general anesthesia therefore implies a condition with which a patient is comfortable. Now, with the comfortable, what do we mean? We mean he should be lying in a proper position for surgery, but he should not be in any pain or agony. He should be unconscious because you don't want a retrograde memory of any such harsh event. So some amnesia should be there, which can be gained by making the patient unconscious, and a relatively immobile surgical field for the surgeons to operate upon. It is not just, general anesthesia is not just used only for surgeries, but it can be used for any procedure which can be diagnostic or therapeutic, or for in the help of certain investigations, like for MRI or CT scan, when the patient cannot lie down, for instance, in the room, lie down straight because of pain. So, and he needs an MRI or CT to be done. Then also we give him some general anesthesia, not that deep one, but at least to make him that much unconscious so that the procedure can be done. Similarly, a patient who is claustrophobic and cannot enter an MRI room and is, in spite of all the sedation, it doesn't work, then general anesthesia is used. So general anesthetics include any agents capable of producing total insensibility, but the most important point is in a reversible manner. So it is once we come for surgical procedures, which we use in the OT, it is a harmless and reversible insensibility which allows operation for considerable magnitude to be carried out without any hindrance to the surgeon and especially to the detriment of the patient. The patient should be comfortable at all times. The basic rule of medicine and principle is first do no harm. There should not be any harm. And for this, the three portions which come into action are the sleep, pain-free part, which is called the analgesia, and muscle relaxation. Now, I really usually tell the story for every student of mine because it's a very, very significant thing to remember that it is not just relaxation. It is proper skeletal muscle relaxation. There has been few instances, and they have been properly documented also, when some nursing staff just read relaxant and gave it to a patient. Now, he or she thought that this drug is to relax the patient so that he should not feel any anxiety or something. And they all led to serious consequences. The muscle relaxation is once your muscles, they stop moving. Now, muscle relaxation does not mean he is under anesthesia because he will be conscious. He may not be able to open up his eye or speak or anything, but his eyes will be closed, but he'll be hearing and feeling everything. So general anesthesia, some drug for anesthesia should always be there before you put a patient on a muscle relaxant. And muscle relaxant is not needed in every case. The peripheral surgeries of limbs can be performed without any muscle relaxation if it's not needed. Like even, and if it's just above the muscle surgery, like a remover of huge lipoma, you don't need that muscle relaxation. So keeping in view about this thing, we should know what the patient's needs are and what the surgical needs are. There are two different things. From the patient's point of view, we have to know the pre-existing state of the patient, what kind of anesthesia can be suitable for him, and once in the operating room, what monitoring is going to be required for that patient. Like if a patient is coming for simple, let's say he was a young adult of 24 years of age and coming for a simple removal of ingrown toenail, but the patient wants to be done at a general anesthesia, not even in local anesthesia, because he has severe needle phobia. So for that patient, you don't need an extensive monitoring, or for the same reason, you don't need extensive kind of preoperative tests for that patient. So the availability, and then we're considering the patient's requirement, we tailor the anesthesia for the patient. Times have evolved, times have changed. Anesthesia has become so much advanced now. These are not in the 40s or 50s. When going under anesthesia, it used to be very dangerous. Now all the drugs are very, very safe. And statistically speaking, for any person undergoing anesthesia, the chances of untoward event or hazardous event are less than, in comparison with traveling on road in Karachi at night. That's a far more dangerous thing. So for induction of anesthesia, there are inhalational induction agents as well as intravenous injection agents. What we are for which patients which we use inhalational agents? In young children who are having upper airway obstruction or lower airway obstruction with foreign body, and the patient with bronchopulmonary fistulas. Now, the problem with general inhalational agents is has a slower induction. It will take some time, and the airway obstruction or bronchospasm can enhance. Inhalational agent can themselves cause laryngeal spasm because of the pungent smell or anything, and the anesthetic agent in the gas can also spread inside the operating room. So the other patient can also get some effect, and the people, they start becoming drowsy. I still remember when I started off my training in anesthesia. So for initial few days, it was notorious that while during the surgery, some of us would literally, get just suddenly knocked out and lie down for a while. And it took some time to adjust, because in our operating rooms, other than the one in Dow University Hospital, most of the operating theaters, they do not have what we call as anesthesia gas scavenging system, AGSS. So until unless you have anesthesia gas scavenging system, there are chances that if an inhalation agent is going around, so other people can also feel sleepy. One has the other. The other route for induction of agent would be intravenous, and for that, IV line is first of all established. IV sources, some IV fluids were started, and then the patient monitoring is applied on the patient. Before starting anesthesia, we make the patient breathe 100% oxygen via face mask. Now, either this procedure is done for 2 to 3 minutes, or the patient is said to reach inspiratory reserve capacity. Remember physiology. Remember something? You guys known as inspiratory reserve volume. That is when you take the maximal deep breath inside and then you exhale. So normal tidal volume is 500 ml for a 70 kg patient, and the inhalational reserve volume with that big inspiration becomes 1.5 liters. And if you take 3 maximal breaths, you get 100% oxygen. The basic aim of this oxygenation is the same oxygen which is in the air we are also breathing in. It is only 21% of the total air we are breathing in. Whereas majority of 69% is nitrogen. And basically with this 100% oxygen, we are denitrogenating the patient or removing the nitrogen part so that more oxygen is there and reserves are there. So in the meantime, we are either intubating the patient when the muscles are not moving, so a patient should not become hypoxic. The hypoxia is the most detrimental condition or complication of anesthesia, and the most sensitive organ in our body. Now, let me see if you can respond by chat. Somebody can. Which organ in the body is most susceptible for any? What is the most important? Yeah, good. So like you guys have gone through that. Yes, brain. Why brain? Why is brain the most important organ of the body? Any idea? Any response? Well, okay. Brain is the most important organ of the body because you can weigh, yes, it's not necrosis basically. See, it is that once a neuron dies, it dies for good. A neuron is never replaced by a neuron. It is replaced by fibrotic tissue. Yes, it cannot regenerate. That is a problem in our brain. Every other cell can. And for every other major organ, if they stop functioning, we still have the option of transplant. Like you can get, if your heart is in a very bad state, you can get an artificial heart. You can get a liver or a kidney from some living donor or from some diseased donor, but you cannot transplant brain. See, and problem with neurons are if they are not perfused. Now there is a difference between circulation and perfusion. Circulation is any kind of fluid which is running around. Perfusion means it has to be oxygenated blood. So if oxygenated blood does not reach the brain for more than 4 minutes, the neurons, they start dying. And then they die, they are replaced. So it's a very, very narrow cushion period in which we have to act. That is why anesthesia is those are the times when you have the full adrenaline rush going on. So it becomes dangerous then. So coming back, the induction agents are basically thiopentone, etomidated, propofol. These are the different groups. Thiopentone and pentothal are from the barbiturate group. They are currently no longer used because of very high incidence of nausea and vomiting. The most common induction agent used in the world is right now propofol. And anybody can just answer me which famous personality is associated with propofol, the side effect of propofol, which landed up with a very major loss of a human life, a person who was very, very famous. Any response? Anybody? Yes, it was MJ, Michael Jackson. What happened was Michael Jackson had, he was severely insomniac. Many drugs he tried, but it couldn't work. So his personal physician came up with this idea. He used to give him small doses of propofol to make him go to sleep. But on that day, what happened was he started off with propofol. He got a call on his cell phone. He went out for a few minutes to answer that cell phone. And when he came back, MJ was gone. Because what happened is with propofol, now I'm telling you this whole story because you should remember now that propofol does cause transient apnea. And if you're giving in a continuous infusion form, it will lead to respiratory depression. So if you are not monitoring the patient adequately, there are chances the patient can end up with severe hypoxic damage. So with the IV induction, what are the problems which can have? Regurgitation and vomiting, most common with the thiopentone group of drugs. Intraarterial injection, especially with, we have to be very careful with propofol, that if it is injected intraarterially, it will cause severe arterial spasm. And the treatment for that is you do not remove the IV line if it's in the artery, you let it remain there and you inject pepaverine. Pepaverine is a very potent vasodilator. You inject that, so the artery becomes dilated and then you remove it. Perivenous injection will cause also severe irritation or burning around it. Cardiovascular depression is common with all the induction agents except ketamine. Now, ketamine is the only agent that will enhance everything. All the other agents, induction agents, they cause respiratory depression, they cause depression and respiratory cardiovascular function, the blood pressure drops. All these effects are not there with ketamine. In fact, it makes a patient hyperactive. It can. It causes increase in every pressure. The intrathoracic pressure is increased, blood pressure is increased, intragastric pressure is increased, intraocular pressure is increased, and also the CSF pressure is increased. So you do not use ketamine for some patient who is already hypertensive or who's already having some cerebral problem. Now, but the age I have now, considering with general anesthesia, the positions, they are very important. The lithotomy position can result in nerve damage once the leg is held up on straight and the stirrups are there and you apply it. So which nerve around the knee can get damage in lithotomy position? Any answer? Peroneal nerve. It hooks around there, so it can get damage. Lateral position, in lateral position, one lung is now down, one lung is up, and why this, what will happen with this thing? Why does a lateral position? We all sleep, once we are sleeping, we always sleep on one side. We don't get any problem. So why under anesthesia lateral position can cause asymmetric lung ventilation? Yes, we change position. This is what I'm asking. You are very right. No, not just muscle relaxation. You see, once we breathe, normal physiological breathing is we create a negative pressure. We create a negative interthoracic pressure. We suck in air, we inhale. So for us, inhalation is active and expiration is passive. So what happens when the muscle relaxation is there, then we are pushing in air. It is called IPPV, intermittent positive pressure ventilation. We generate a pressure, we push in the air, and then we stop and we allow the lung to recoil, so expiration will happen. Okay. But once you put a patient, now with this positive pressure ventilation, remember air always goes up. Okay? So the air will start going more towards the upper side, upper lung, less towards the lower side. So ventilation perfusion mismatch can start occurring. So, but if you keep the flow rate high, then even in lateral position, both lungs can easily be expanded and no complication can arise. With the low time of volume and everything, asymmetric lung ventilation can lead to VQ mismatch. So with this VQ mismatch is very significant, especially in thoracic surgery. So for that reason, in thoracic surgery, we do one lung ventilation. We isolate both the lungs. So with both the lungs, we get so that once the surgery is going on in the right lung and we have inserted a double lumen endotracheal tube, we isolate the right lung. We do not give air into the right lung. We let it collapse so the surgery can occur, and we only ventilate the left lung. In this way, the ventilation perfusion mismatch will not occur. The prone position, well, it can always cause compression on the abdomen. Now, if our abdomen will not expand, how will the breathing occur? So we have to make sure that there are pillows beneath the chest and at the pelvic region, but the abdominal area should be free. With the Trendelenburg position, it gets, especially now this inverse position, consider yourself, head down, legs up, so the abdominal content pressure will be on the diaphragm. So it will require more effort to raise the diaphragm. With the sitting position, yes, a sitting position. Any idea which surgery will be performed by making a patient sit? You appropriately adjust the operating table in such a manner that it becomes a sitting position. For which surgery we might need this thing? No, spinal cord is down. For spinal cord, you make a patient prone. So again, for spinal cord, you make a patient prone. Dental procedures, no. For dental procedures under anesthesia, it will become easier to give a proper full anesthesia, intubate the patient, open up the mouth, and then do the surgery. Any idea? Well, it's done for posterior, yes, for brain, wonderful. It's done for posterior fossa surgery, posterior cranial fossa surgery. Once you are in OT, do come to me and I'll show you the picture and everything, how it's done. So for the posterior fossa surgery, you make a patient literally in a sitting position and you apply special these rings along on the head and you keep it static over there. So it's for posterior fossa surgery. And for supine position, it can cause hypotensive, like why will hypotension occur in a pregnant lady? It will compress the inferior vena cava. And with inferior vena cava compression, the venous return will be less. If the venous return is less, the cardiac output will be low. So it can cause hypotension. Now, this is not, it's just anesthesia. General anesthesia is like flying an aircraft. The most dangerous parts are the takeoff, which is the induction, and then the landing, which is the reversing of the anesthetic agent when the patient is coming out. In the meantime, the flight can become turbulent because of surgical manipulation or anything, because of blood loss, surgical manipulation, patient positioning, any complication. Other than that, usually the maintenance is, if everything is all right, the surgeries go on smoothly and the maintenance remains uneventful. And for maintenance, what we can use, we can combine inhalational with spontaneously ventilating a patient, which as I told you, that if a patient, like if there is removal of a lipoma, or even if there is bone fixation for fracture radius ulna, you don't need a full muscle relaxation throughout the body. So why to paralyze the patient? You can simply give inhalational agent. We start off with it. We give an inhalational agent, insert a laryngeal mask airway, no need to insert an endotracheal tube, and continue with it. We can also give inhalational plus controlled ventilation, in which we relax all the muscles. And there is another thing, IV with spontaneous ventilation and IV with controlled ventilation. Both these things, C and D, they come under the term TIVA, total intravenous anesthesia. The best part of total intravenous anesthesia is in this condition C. With spontaneously ventilating a patient, we give just intravenous anesthesia and we maintain that anesthesia throughout. The good example for this thing is like endoscopic procedures. Or in outreach anesthesia, where you don't want the whole anesthesia machine to come along, but it should be there as a reservoir for in case of any need. But total intravenous anesthesia agent combination with spontaneous ventilation and a good analgesic. Propofol infusion with remifentanil, which is an opioid, are the ideal drug for doing a neurosurgery. Very good response with that. Even we have done awake craniotomies with simple blocking of 7 different nerves which are supplying the scalp, and but it will be a single-sided, not bilateral. And we have done, even in our Dow University Hospital, we have done 2 cases of awake craniotomies when the patient was fully conscious, understanding everything. Any surgery which you can think of in which you require proper awake patient neurosurgery, and you want a patient to remain awake? No, not cerebrum involving, in fact. Cerebrum is higher mental functions. It's once you are operating on the brain stem along the basal ganglia, especially, and you do not, and you keep on communicating with the patient so that you should know that you are not touching or disturbing any part which is in the basal ganglia, which might get disrupted. And also for correction of scoliosis on the spinal column, yes, on the vertebral column. Because once you are correcting the scoliosis, we make a patient wake up and we ask the patient to move the feet. Yes, during the surgery, but however, for that, we give adequate pain relief. We make sure the pain is not there, but we make a patient move the limbs so that you make sure that you have not overcorrected the deformity. And spinal cord compression is not occurring. Another beautiful advance which has been made in neurosurgery is the insertion of some stimulator for inside the brain stem, which is done in total intravenous anesthesia, making a patient conscious, for in which patients have the patients of Huntington's chorea or any abnormality in which the patient has severe tremors or coliform activity because of the basal stem hyperactivity. And literally these electrodes, it's called deep electrode insertion. And once you place it there and the patient is having severe tics, and suddenly all his tremors, they stop. And it's worth a sight to see the response of the patient suddenly becomes so relieved. So, but currently we are not having deep insertions in Pakistan, but deep electrode insertion, hopefully they'll be coming soon. Now they have worked very nicely, especially with the senior citizens who have severe tremors. Now, these things. Now, the complications of inhalation anesthetic. Inhalation anesthetic agent we will cover in the pharmacology also. What are they? Basic, most commonly used are sevoflurane. Then there is isoflurane. And sevoflurane and isoflurane are the most commonly used. Then there is also desflurane. You need a more proper equipment which can supply it the amount of volatile inhalational agent. All these are called volatile inhalational agents. So that they are volatile because they are fuming up, getting mixed up with the air which is entered into the patient and is sterile. They can, but all these things. And now remember this complication, malignant hyperthermia. That's a very, very dreadful complication. And it occurs 1 in 20,000 to 1 in 40,000 patients. It is very, very rare, but it is a response in which the temperature of the patient touches like 40s. And it's very severe. It's like imagine 106 degrees of Fahrenheit. And the whole body is literally burning up. It initiates a trigger. Some patients are especially prone to it. So what we encounter, we try to counterform by taking the history of the patient, the detailed history of the patient. And if he has a history of any complication of anesthesia in the family, then we take a muscle biopsy and tell him so. He should always tell the patient or carry a tag around that he is susceptible to malignant hypothermia. All the inhalational agents that cause malignant, they can trigger malignant hypothermia. And one muscle relaxant, succinylcholine, these drugs can trigger malignant hypothermia. So the treatment of malignant hypothermia is dantrolene, which is a calcium channel blocker. It needs to be mixed up and given, but it is very cumbersome to make, but usually it is 99% of the time malignant hypothermia is fatal. Now, inhalation agent can be given by a face mask, laryngeal mask elevate, or ET tube you're seeing. Face mask comes in different sizes. What we do is we apply it completely so that a seal is formed and the dead space is given a gas-tight seal and patient can be ventilated. And you can further enhance this airway maintenance by inserting a Goodell's airway. Yeah. The laryngeal mask airway is a wonderful device. You do not need to pass, you do not need a laryngoscope with it. You simply open up a mouth of the patient, pass a laryngeal mask airway in it, and with that, you can ventilate the patient. There is a cuff in it. Once you are inside in the OT on your rotation, do come around and we'll show you practically how the laryngeal mask airway. It's very, very simple to insert. Now we have made it a part of crash trolley also. And you can ventilate the patient with also, but at the same time, there are chances of regurgitation. So for that, in those patients which are having hiatus hernia or reflex esophagitis, it is contraindicated. And of course, if the surgery is in the pharynx because the whole bulb is lying in the pharynx, you will need, this cannot work. Endotracheal tube is the most definitive way of securing an airway. The securing of airway. Why do you want to secure an airway? Because you don't want to end up in a situation where you have given the anesthesia and you are unable to ventilate the patient. Then the patient, after 3 minutes, the hypoxic damage will start and the patient can die. So most of those SUE cases or procedures, or you see in the movies, a patient went on anesthesia and died, is because of can't intubate, can't ventilate scenarios. So other than that, endotracheal tube is the choice of like definitive securing of airway. The patient, it is the safest way to secure an airway and for any surgery is insertion of endotracheal tube. Now, muscle relaxation, you need why do you need a muscle relaxation? Just as I told you, so sorry. Yes, so this is it. So it alternated with spontaneous ventilation as well, because it will reduce the requirement of inhalational agent, the neuromuscular relaxant, and it will help with the surgical procedure in the abdomen, in the thorax, especially all the major abdominal, intraperitoneal, thoracic surgeries. And intracranial operations, those in which the whole major area is involved. A burr hole can even be done under a local anesthesia. With assessment of muscle relaxation, autonomic reflexive activity, you see, like, how do you know the patient is adequately in anesthesia? This thing is something of the past. But what we use is for muscle relaxation, we use something called TOF, train of force stimulus. It's a small machine and you see the response. It will give four small currents. You apply it on the thumb or on the forehead, we see the response of the temporal muscle or the for the thumb, external hallucis longus, and you apply it and you see the thumb twitch. If with the 4 impulses the twitch doesn't occur, that means he's in the depth of anesthesia is adequate. Even if the 4th twitch, the thumb moves slightly, the muscle relaxation is adequate. But if it's first or second twitch also, even if the 3rd twitch also the muscle is moving, then the muscle relaxation is not adequate. You will need to deepen the anesthesia or give more muscle relaxation. For awareness of anesthesia, we use this is bispectral index. It's a small, like an ECG pad. It is applied on the forehead and it will give you the depth of anesthesia in numerical value. 40 to 60 numerical value of BESS is adequate for general anesthesia. 60 to 80 is for sedation, and above 80, the patient is conscious. And okay, small increments, 25 initial dose of muscle relaxant is given. And at the end of anesthesia, we reverse the effects of these drugs. And for that, we give a relaxation, neostigmine plus atropine. And we see how do we know that the patient is adequately reversed? The spontaneous ventilation will start taking place. The patient will be able to breathe appropriately. Oxygen saturation will be maintained, but most importantly is should not be retaining carbon dioxide. So end-tidal carbon dioxide monitoring is called capnography. These are the old days and they have long gone. Then is the local anesthesia, which we do not need over here. But to one thing which we need to do more is, hold on, for that.